Hello, everyone. I'm Damian Cabrera. I'm the program manager for the treatment division, and I am super excited to have this conversation around injectables. It's something that we have learned a lot from the new technology. We know that there are different technologies on the pipeline, and finally, we have another one. So this webinar is directed towards informing the community about what this technology is about so that they can take informed decisions, and also too for other organizations and other community members that are tasked into developing messaging that resonates with the community, kind of to give everyone hints about how that may look like. And for today, we are going to have as panelists Russell Campbell from HANC, HIV/AIDS Network Coalition, Michael Starrett from the National Institute of Mental Health Division of AIDS Research, and also Carlos Negrete, who is a Gay Men of Color Fellow from NMAC. And for those of you that don't know, the Gay Men of Color Fellowship is centered on developing messaging from the gay men of color community to other community members. They develop their message, they develop their concept, and we kind of support on developing those visuals. If you want to learn more about this campaign, please make sure that you search throughout social media for the hashtag GMOC, and you will find all their designs that they have been posting. And also, before we start, just a small announcement. As many of you know, NMAC and CDC have partnered for help them spread the message about the Let's Stop HIV Together campaign. You can access that link that communications is going to put on the chat. There you can find information for your social media or your organizations or community members about treatment, prevention, stigma, and they also have a zip code search so you can identify services that are closer to you. So with further ado, I know we have a long conversation. Please make sure that you put your questions on the chat. We will address them at the end of the webinar. So without further ado, I'm going to pass it over to Russell and Michael. Thank you for being here with us.
Thank you for inviting us. This is a wonderful opportunity for us to talk with you all about some of the work that we're doing at HANC, which is the Office of HIV/AIDS Network Coordination. My name is Russell Campbell. I'm the Deputy Director there. Next slide, please. So for those of you who may not be familiar with HANC, we are based at the Fred Hutchinson Cancer Research Center in Seattle, Washington. And we work with the 4 National Institutes of Health HIV/AIDS clinical trials networks, and they're listed in there, ACTG, Impact, HIV Vaccine Trials Network, and HIV Prevention Trials Network. And our focus at HANC is to focus on collaboration and harmonization across the networks to ensure that the networks aren't duplicating efforts, and just to make sure that we're focusing on doing the best we can to provide information globally for these networks who conduct research. Next slide, please. One of the areas of coordination at HANC is community coordination, and I am pleased to be the director of the Legacy Project. And the Legacy Project focuses on addressing those issues that have resulted from historical abuses in the name of research that have disproportionately impacted communities of color. And as I think most of us are familiar, communities of color are disproportionately impacted by HIV. And so what we try to focus on is engaging those communities, researchers, site staff to address those issues, so that the goal is to try to increase participation of those communities that are disproportionately impacted by HIV. And one of the ways that we do that is similar to what we're doing today, is by focusing on providing information and having engaging conversations around what do communities need, what would communities like in terms of information. And so this conversation today around long-acting injectables is really important to us. And one of the things that we've done is we have developed some materials focused on those communities that are disproportionately impacted by HIV so that we can provide information to those communities that's culturally relevant and meaningful. And so what you see here is an example of some flyers that we've developed around long-acting injectables. Next slide, please. And this highlights where these where you can download this information for free. It's on our public site, and you can access this information at www.hank.info. And this is just just an example of what we do. And so we'll be going into this into greater detail. And I'm delighted to introduce you to Dr. Mike Starrett, who has been an amazing collaborator of ours, and we've had an opportunity to collaborate over the years and work together. And he's going to go into more detail about long-acting injectables. Is this the future of HIV treatment and prevention? So, Mike, thank you.
Russell, thank you so much. And great thanks to NMAC and to the Gay Men of Color Fellows Program for inviting us to be a part of your session today. We really appreciate it. We're going to continue the theme that Russell has already started. The Legacy Project has offered some excellent information about these long-acting regimens, which is available for download. And I'll share with you, some of the latest information that we have about these new injectable and long-acting regimens for HIV treatment and for HIV prevention. Both Russell and I work alongside many of the clinical trial teams that have developed and tested these regimens. And that's always a long road, to see something come forward, ultimately be proven, and then go on to use, in our communities. But we're at a really interesting juncture of that road right now, where we do have a few of these injectable regimens that have now emerged, are proven, and are just starting to be taken up. So this is a very timely session, and I hope that we can answer many questions for you. Where you may have questions that we don't happen to have a good answer for, there are some things that we just don't know very well right now, or there may be some things that Russell and I don't know ourselves. But we will find the answers to any questions that people ask, and are happy to report those back if there's something that we can't address today. So just to go forward, we are talking about the idea of long-acting HIV treatment and prevention. And this is this exciting juncture where we're moving from using a medication or a product, moving its use from something that's daily to intervals of weeks or months. And the idea is that if we can develop medications, medicines, drugs that are long-acting and that do not require daily use in order to be effective, that could help relieve people of the burden of taking pills on a daily basis. And it could have a number of other beneficial effects. So this is something that researchers have been working on for a very long time. And there's actually a really wide range of different kinds of long-acting regimens that are either currently in clinical trials or are currently in development. The ones that we'll be talking about today are these long-acting injectable antiretroviral drugs. Those are used for HIV treatment and HIV prevention. Those are the ones that have come the farthest and are now FDA approved. But somewhere behind that, there's a whole range of other long-acting regimens that are in development. And so here we'll just mention things, only in passing. Infusions of broadly neutralizing antibodies. You've already heard about the use of these kinds of broadly neutralizing antibodies because there was a version of them that was used as a treatment for COVID for a period of time. And people are working on that for HIV treatment and prevention as well. But those remain in clinical trials. And then there's other kinds of regimens too. The pivoring vaginal ring, People are working to develop oral medication regimens that are only taken on a monthly basis. There's also the possibility of extended release drug implants, where people receive like just a small implant, in their arm that slowly releases drug over time. And then there's other ones like microneedle patches, which is something that's a little bit more on the frontier. It's kind of like a more complicated Band-Aid that delivers some medication to people. And arguably, our continuing efforts to identify a vaccine for HIV fits under these long-acting methods, since our hope is that an HIV vaccine would be something, even if it required multiple administrations, that would actually have long-lasting benefit for HIV prevention and treatment. So this is to say that there's a tremendous amount of research and activity in this space, and that it's happening among a variety of different products and approaches. The first one, of course, out of the gate being these long-acting injectables. And the thing that makes it exciting is that, if one or more of these approaches do become proven and do become available for use, it expands the choice that people have, the options that they have for their HIV treatment or for their use of HIV prevention. And the idea is that people can pick the method that works best for them, the one that they prefer. For some people, that would be a daily pill. For other people, it might be one of these injectable regimens. We're not here to encourage you to use one or the other approach. We just want to give you the best possible information. And ultimately, people will have to make those decisions themselves, in consultation with their medical providers. So to go into the injectables, or actually just to give you a little bit more of context before we talk about the injectables, it is helpful to think about kind of how far we've come in HIV, and I think in particular about how far we've come in HIV treatment, because there really was a time many years ago now when there was no effective treatment for HIV, and it was just a tremendously challenging and difficult time, and there was an incredible amount of advocacy that came forward, to push the FDA, to push drug makers to find effective treatments for HIV. And we're so fortunate that the development of combination antiretroviral therapy did occur in the late 90s and has subsequently substantially reduced mortality from HIV in the US and even around the world, wherever treatment is available. You see that line there, that big drop. So that's an incredible advance, and it's one that we're very fortunate to have in HIV. The reason I make note of that is because, to me and to I think many of us, getting that advance of highly effective oral combination antiretroviral therapy, that's a credit not just to the science that produced it, but it's also a credit to the community, to the advocates who marched on Washington, who were outside of the FDA, and who were really trying to create change to both promote and speed the development and testing of these regimens. And so it's a credit that we have these powerful regimens is a credit not just to science, but it's also to the community. And I really think it's a legacy of both of those things. The subsequent story of HIV treatment has been one of developing ever more potent and effective, as well as highly well-tolerated and safe regimens over time. So, when we began with oral antiretroviral therapy, the regimens were frequently very toxic. And people who were on those early regimens also had a tremendous pill burden. There were some regimens that required the users to take a pill as many as 4 or even 6 times a day. We had people who were so concerned about getting the best benefit from their medicines in a time where AIDS was still something that was extremely deadly, was, they're waking up in the middle of the night. They're setting timers so they could take their pills in the middle of the night. And what's happened over time is that we've been able to develop regimens that are simpler, that are better tolerated, and that are safe. And so it is incredible to think of how far we've gone, where people used to take a whole constellation of pills to manage their HIV. Now, the majority of people in the United States who are newly diagnosed with HIV will start on a 1 pill once a day regimen. And so that's really a tremendous advance. And we have really good evidence to suggest that, when you do simplify regimens like that, it does make it easier to take the pills. It doesn't solve every problem, but it is helpful to have a reduced pill burden. So we're grateful for that simplification. And in many ways, these new injectable regimens kind of represent an extension of that, to further simplify these regimens, or at least that's the hope. So what are long-acting injectables? Well, over time, what we've learned is that there are certain formulations of antiretroviral drugs that can be delivered as a long-acting injection. And the preferred method of delivery for these injections is to give them as an intramuscular injection, and that's in the glutes, and it's delivered by a healthcare provider. Now, these regimens for HIV prevention and for HIV treatment, they currently allow for bi-monthly administration. So instead of taking a daily pill, people might receive one of these injections every other month. And that would be the simplification there, no longer daily use, but instead, bi-monthly use. And the reason that that's possible is because some of these drug formulations can last a tremendously long time in the body. And there is some early research, which indicated that at very low levels, they can be detectable in some people as much as a year or more after the first injection. But the current regimens, it was 2021 was kind of the signal year for these injectable regimens, because it was in January of 2021 that the FDA approved the first regimen for HIV treatment, long-acting regimen for HIV treatment, and that is now called Cabenuva. And you see that here on the right, long-acting cabotegravir and rilpivirine. That's for HIV treatment. It's the combination of 2 injectable drugs. And then it was late in 2021, I think it was December of 2021, that the FDA approved one of these long-acting regimens for prevention, HIV prevention. So, and that regimen is marketed as Addictophobia, and that's an injectable version of cabotegravir. And again, that's for HIV prevention. So what I'm going to do is take just a little bit of time to talk about each of these things, treatment and prevention, and then I'll conclude by noting some of the ongoing challenges in scaling up access to these regimens. So what are some things to know about long-acting injectables for HIV treatment? So here we're thinking about people who are living with HIV, people who are currently on or need to access or would benefit from HIV treatment. So as I said, that's Cabenuva, which is this combination injectable regimen. And originally, this regimen was going to be monthly, but very recently, just a couple of months ago, the FDA approved a new bi-monthly dosing schedule for this. So that means that individuals who transition their HIV treatment to this injectable regimen would receive as few as 6 injections per year. And they know that they were able to do that because of trials that compared the monthly use of these medicines to bi-monthly use of the medicines. And what they found is that they were equally effective, whether they are administered on a single month or a bi-monthly basis. And they also learned that people greatly preferred to have the bi-monthly regimen, that the people in these trials much preferred coming in once every 2 months rather than coming in once monthly. So these are some reasons that the FDA has approved a bi-monthly regimen for treatment. They are safe and effective based on the clinical trial evidence. The clinical trials that tested these regimens for HIV treatment compared them to oral antiretroviral medications. And in multiple trials now, what they see is that the long-acting regimens are equivalent, or they'll use the technical term is non-inferior, but they're equivalent in their effectiveness to oral ART. Basically, oral ART and the injectable regimens, they work just as well as each other. Now, the individuals who've been in these treatment trials, there's been qualitative research and survey research with them to understand what their experiences are. And what people will say is that receiving these injections does involve some mild to moderate pain. They are intramuscular injections. If you've had an intramuscular injection, you will remember that you had one. They're deep. But despite that pain, what most people say is that it will resolve in 2 or 3 days, and that the users of these regimens in the clinical trials really preferred them. They preferred them to oral treatment. And the reason that they preferred it is because they say that they didn't have to worry about taking a pill on a daily basis. They didn't have to worry about concerns like HIV stigma if someone is, watching you take some medication. And it just helped to simplify their lives. Now, 2 things that are really important to know about the treatment, though, is that this long-acting injectable HIV treatment, it's really developed as maintenance therapy. And what do I mean by that? Well, what I mean by that is its current indication is that it's indicated for individuals who have already achieved viral suppression on oral antiretroviral medications. So the current FDA recommendation is that individuals become virally suppressed on oral antiretroviral medications, and then once they achieve viral suppression, then they can transition to these long-acting injectable drugs. The reason why is because there's a question about how effective the injectable drugs are for achieving viral suppression as opposed to maintaining viral suppression. They're very effective at maintaining viral suppression. We're certain of that. But achieving viral suppression is another question. And that's something that there's currently research ongoing about. So for the time being, to use these regimens, you would have to be virally unsuppressed, a person living with HIV who's already virally suppressed on oral therapy, and then you could transition to the use of the regimen, the injectable regimen. And then one other thing to know is that there are some, in the research to date, there are some very rare cases where it does look like there's been viral breakthrough, even though people have been faithfully taking their injections. And there's still research to be done to try to understand why that's happening. Was it an issue with the way the injection was delivered? Does it have to do with some kind of form of resistance that is not yet currently understood? Does it relate to body mass? There's just a lot of ongoing questions that are happening there. But those cases are rare. Overall, the regimen has been proven safe, effective, and is now FDA approved and is available today, in locations across the United States where people can find access and have the healthcare coverage. We'll talk about that in a second. I want to say one other thing about HIV treatment, the long-acting injectable HIV treatment, and that is that the research continues. Russell and I both have some involvement with this project, which is called the Latitude Study. The Latitude Study is an ongoing research trial that's testing long-acting injectable treatment. It's currently open for enrollment at 26 clinics across the United States. And the thing that's exciting about the Latitude Study is that it's evaluating these long-acting regimens in individuals who are living with HIV who also have adherence challenges. So it's a trial that's specifically trying to enroll people who have been challenged in their ability to access the benefits of oral antiretroviral therapy. This may be people who lack full viral suppression or have an inconsistent history of viral suppression. It may be people who are in and out of care. And we want to make sure that the regimen will work for everyone, and especially this group of individuals who are not presently benefiting from oral regimens. So that trial is ongoing right now. They're enrolling in sites across the United States. And if you want to have some more information about that study, if you think you might be interested in it, or if you think that you know someone who might be interested in it, you can find out more at this link, which is at the bottom of the screen here. It'll be great to see that work come forward. So, so far I'm just talking about treatment. Let's talk about prevention. So long-acting injectables for HIV prevention. So this regimen, Addictophobia, was FDA approved, as we mentioned. It's broadly indicated for adults and adolescents. And they look at this in terms of people's weight, that they're an adult or adolescent that weighs at least 77 pounds. So that's really very inclusive. The way it works is that people do take about a month. Generally, people will take about a month of oral PrEP, and that's to lead into the regimen. And then afterwards, they get 2 shots that are 1 month apart. That's kind of the launch of this, the start of it. And then after that, people get bi-monthly injections. And so these are for individuals who have tested HIV negative. And in the trials today, 2 of the major clinical trials, their pictures are here, HPTN-084 and HPTN-083. What they found is that this injectable PrEP, which is basically delivered every other month once you complete that starting regimen, is not only safe, but when they compare it to oral PrEP, they even found it superior to oral PrEP for HIV prevention. And what we mean by that is that in these research trials, which have been conducted with cisgender, same-gender loving men, gay men and MSM, as well as transgender women and cisgender women, what those trials tell us is that actually we do see lower acquisition of HIV in individuals who are receiving the injectable regimen than in individuals who are receiving the oral regimen. Now, there's an important thing to say there, and that is that the oral PrEP is still incredibly effective. It works. And so oral PrEP works. It works when taken. But the reason why in these trials we think that we see that the injectable regimen was more helpful at preventing acquisition of HIV than the oral pills is, again, because of the adherence issue. It's just very challenging to take pills on a daily basis. Life gets in the way sometimes. That the adherence to these bi-monthly injections is something that people were able to do, at least in these trials. In these trials, they were able to do it very well. And so the improved adherence in those trials is what let people get a greater benefit from the injectable regimen than the oral regimen. So it's an interesting thing, and we can talk a little bit more about that if there's questions. Things to know about this is that people must test HIV negative before they start the injectable PrEP. The reason why is because the injectable PrEP is not a treatment regimen. It's basically monotherapy, and so they would worry that if somebody had HIV infection and started on this regimen, they might develop drug resistance and that it wouldn't be effective for treatment. So they will do lots to make sure they do HIV testing at the start before someone begins this regimen. And they also want people to do HIV testing at regular intervals when they receive the injections, just to make sure that they continue to be HIV negative before they receive it. Now, there are some very rare cases of HIV infection, and this is despite the good adherence. We noted that also in the HIV treatment. This is an area that they're trying to understand that. They're doing that work right now to try to better understand what is producing those cases. That's an area of ongoing inquiry. Nonetheless, they are very, very effective based on the accumulated clinical trial evidence. And the other thing to know about this is that the long-acting injectable PrEP, really actually for treatment or for prevention, people kind of think of it as either or. Either you're doing the oral drugs or you're doing the injectable drugs. But the truth of it is that they're really kind of braided. They're kind of braided. And what I mean by that is that, what you'll see is that, people will start on an oral therapy or an oral regimen, to make sure that they don't have any reactions, to make sure that it's fine, or in the case of treatment, to achieve viral suppression. And then they'll transition to the long-acting regimen, and they could well stay there. But if they should decide to stop the long-acting regimen, then there's going to be a role for transitioning people back to an oral regimen. So people who decide to stop a long-acting injectable PrEP treatment will almost certainly benefit from having oral PrEP afterwards. And that's just to make sure that there's enough drug on board to maintain a preventive effect, to make sure that people don't acquire HIV when they come off of these regimens. So this is what I mean by, kind of braided, that, it might be, oral, long-acting, oral, depending on how people use these things, going forward. So, there always will be a role for some of the oral medications, I think, one way or another. Let me finish now by just highlighting what some of the possible opportunities and challenges are. And I know that we'll have some more discussion of this. So it is exciting to have these new regimens, in particular because of the benefits of choice. When people have multiple regimens that they can choose from, they can choose the one that best suits their own interests, their own preferences. And, in the case of oral versus long-acting injectable, some people will choose one and other people will choose another. We have people who have been on oral antiretroviral medicines really for, years, for, a great proportion of their life. And there are many people who do very well on those oral regimens and who've kind of learned, how to fit that into their lives. Those are individuals who may not want to make this change. Conversely, there'll be others who'd be interested in trying something different, something new. So we want to be able to give people the choice. Some people will prefer these regimens, other people will not. But the people who do prefer the regimens tell us that they see them as a way of reducing the burden of medication adherence and also reducing the burden of HIV stigma that can sometimes be involved in taking medications in one's home or community locations. And then as we saw in these clinical trials, there's also the possibility that the long-acting regimens will actually improve our HIV prevention and treatment outcomes, that we'll see a better effect, more reduced HIV infections, better benefit from HIV treatment through the use of long-acting regimens. So they have that promise. Now, to realize that promise, though, there's enormous challenges. And the first one is cost and healthcare coverage. These regimens are currently priced exceptionally, they're very expensive. And because they're new, the healthcare coverage arrangements for them is still something that's being worked out. In a very early study that was conducted in California in one site, it was only individuals who had private insurance who were able to access the long-acting HIV treatment. And so it's, anything that's new requires, some effort. To pioneer, the procedures and the policies, to supply the healthcare coverage for that. So that is an ongoing issue, making sure that we can have healthcare coverage for these regimens, and that their cost is worth, that people can benefit from them as much as possible. That means making sure that they do have equitable access and even global access, to these kinds of regimens. And I think, many of us, are concerned. We look at the history of things like oral PrEP and where we stand on the use of oral PrEP today. And we know that there's just a tremendous number of people who would benefit from oral PrEP who are not currently taking it or who do not currently have good access to it. And that there's, terrible inequities along the axes of race and ethnicity and age and gender, that make the current access to it very inequitable. So we worry about duplicating those inequities with these new regimens. That's going to require concerted effort. And then there's also just an issue with the delivery of these regimens in healthcare systems. Our current healthcare systems, our current providers, they know oral medications. They know them well. They know how to prescribe them. We can get them at our local pharmacy. There's a train track on which to run, that railroad. Well, this is a different operation, involving people that come back to the clinic on a bi-monthly basis. It requires a different set of organizational skills to make that system work and to make it work on time. So, the clinicians and the healthcare delivery organizations, they're telling us that they're still working on this. They're still trying to work out how to best support, the use of these regimens, and that's another challenge that's ongoing. So, there's a lot of possibility here, but many challenges yet to come. So I'll conclude, just by thinking about the broader treatment and prevention outlook here. And I like this picture. You can kind of think of, where we're at today as having summited, a very tall mountain. There was a time when people were desperate for highly effective medications to treat HIV and to prevent HIV acquisition. And today we have those, and that's just an incredible advance. So we stand atop a very high mountain. At the same time, now we have these new regimens that are arriving, the injectable ART and PrEP. Well, those are also, there's a beautiful view there too, but to reach that, we still have a few more hills to climb, to really realize access and best use and benefit from these new injectable regimens. And if we look farther out onto the horizon, you're really into the many years from now, we have a number of, set of long-acting products that are in development and that could come our way. So this is a landscape that's going to continue to change and to evolve. But it's exciting to, go forward in it and to go forward in it together. So I will conclude there, and I appreciate the opportunity to speak with you all. And I think that we will now transition to our additional speakers. Let me pull that up. Okay. Let's see. So I think that we now had some discussion, and that was that from Carlos Negrete?
Yes. Yes.
Yes, Carlos.
Yes.
We welcome your comments.
Yes. Thank you. First, I would like to thank NMAC for allowing me to be part of this. I'm here as a queer man of color, but also I'm here as someone who works in the field. I'm a disease intervention specialist for Multnomah County Health Department, and here to share some thoughts and recommendations around having this conversation with patients, clients, whoever you work with, and how do we make sure that this information gets to the community in a meaningful way. I think first you need to understand who you are and what's your power in the community. So if you are a provider, a pharmacist, or a clinic, think of your environment and the environment that you are creating for the community. Do they feel like this is a safe space to have this conversation? Are you allowing them to have that safe space to ask questions about sex? Because I feel like a lot of the times, yeah, we want people to know that they have the choice to prevent this, but they don't even know that they are at risk. We are highly impacted by it, but because we don't have the conversation around HIV and how we are highly impacted, we don't see it as something that is going to impact me. We see it as someone else. The language and the way that we educate people, I think, should be more around the actual behavior and not the identity, because not a lot of, I like how people here were saying men that have sex with men, because some people that have sex with men don't identify as a gay man. So giving people the opportunity to identify the behavior, but without putting an identity to it. To empower the community to ask questions, and make sure that the education is very simple and clear. It doesn't have to be long and scientific. It can just be to the points, like bullet points, what we're talking about. If you're doing this behavior, if you identify with this thing, then people can ask a provider more into like get into an injectable, or what does that look like. One of the barriers that I feel like we're going to face is obviously costs with or without insurance. So I think this is something that needs to be addressed right away with the community, especially for folks that are undocumented. This is something that could be very triggering, and they might feel like they don't even qualify for it. So we need to address that right away without any stigma or shame. Making a process to make it as simple as possible for the patient to schedule an appointment, and to make sure that there's not a lot of barriers that come. If you can take away a barrier from it, just check in within your systems and what you're doing and what can you get rid of to make sure that there's lower barriers for the patients to access this medication. Don't make it your agenda. Again, make sure that people know their own risk, and then they can make the informed decision about what choices they want to make. I like that we talked about here about, you know, the pill might be something for you, but if you want to do the injectable because it feels like it might work for you, then you have that option, but we're not trying to push anyone to go in one direction or the other, but just empowering each other. Listen to the community, talk to the community. One of the things that we're doing in the fellowship is make sure that obviously the materials are being created from the community to the community, and that we're speaking not just in the language, but in the culture and we might communicate in a different way that other people not in the community will understand. I think those are all of my thoughts and feedback, and I'm happy to, obviously I'm not speaking for the community. We welcome any feedback from everyone else. And I'm just excited that we're in the table having this conversation right now.
Carlos, this is Russell. Thank you. Can I ask you a couple of questions, if you don't mind, just thinking about some of the points that you raised around messaging. What do you think are, or how would you suggest going about, you know, getting that input from community to think about? You mentioned making sure that the language is clear, not getting muddled into, you know, scientific lingo, and, you know, empowering the community. What are the best ways do you think we should approach that when we're looking at things from the research side to make sure that there's that community involvement in whatever we do, to make sure that, you know, community understands what we're talking about when we're talking about, you know, long-acting injectables? Do you have any suggestions for that? Thank you.
Yeah, I mean, just thinking of examples that people might be more familiar with. For example, when I'm talking to patients that have never heard about PrEP, and I talk to them about, like, sometimes people like to think about it as like the birth control of HIV. People know what birth control is. People know that it's a daily thing. So the message, somebody, when I say that, they automatically get it of like, oh yeah, like I have to take this pill every day, even if I'm not having sex on those days. And I like the flyers that you all created. And I think that moving, like, as you know, technology is moving forward and more things are on social media, one thing that we're trying to do is, like, when we create a flyer, to make it with just like the thing that what we want to do, the call of action, like injectables to prevent HIV. This is how it kind of helps, but just like bullet points, and then like a barcode or something that if people want to learn more about it, that they want to actually read more into it, then they can go into it and go into it. But don't present that much information at the beginning. Allow them to kind of like question themselves, like, oh, that sounds interesting. Where can I find more? Oh, below. And then I can click on it and then get all this like information that they obviously want to read. Does that answer that question?
Yes, it does. Thank you. The follow-up to that is, do you think community forums and sessions like this are a good way as well to have the exchange to get some of that input? Because what you've just shared is very helpful, and that's something I was just taking some notes to incorporate that. Thank you.
Yeah, I think this is really valuable. I think that all clinics, nonprofits, anyone that's listening right now should really think about how much input are you getting from your patients? Like, how often do you do a quick survey of like, what would you like us to do? What do you like about our building? What do you like about the posters we have? Like really, really have the patient feel like this is their space, and they can have more of an agenda of like, or more of a choice on what comes into the building. Because when they walk into the building and they see a poster with someone that looks nothing like them, they don't have any language that speaks to them, then they're like, well, I don't really feel comfortable. This is very clinical. This is very this or that. So get some input from your patients. This is awesome, but also let's think about the patients that we're seeing every day and what input are we getting from them.
Thank you.
Yeah. Are we opening the floor for questions? Not sure.
Yes, I was looking in the chat. I don't see anything right now.
Yes, we actually do have a few questions.
Oh, sorry.
So,
I didn't see. Sorry.
Yeah, sorry to interrupt. We do actually have a few questions, so I can go ahead with those now. One first question, I understand that there may be some background resistance due to past medications taken. The injectables may still need to be once a month. Is that your understanding as well?
That is a choice that would be made, between the individual and their healthcare provider. They now permit a bi-monthly injection, and so that is allowable. But there may be individuals who, for a variety of reasons, may feel better about accessing it on a monthly basis. That was the original basis for HIV treatment. One reason to do it on that schedule might be to ensure that there'll be good coverage of the drug levels, especially if there might be any, surprise, delay in the receipt of the next injection. Basically those choices are available, to receive it in either way. But again, it becomes a choice, because to come in monthly, that it requires that commitment, to being willing to come in monthly and to take the time, to set the time aside in a day to make that monthly appointment. The people who've used it to date have said that they preferred the bi-monthly, but that option is there. That's right.
Okay, the next question. Did either trial have any SU or IDU exclusion? If not, did you have any issues with adherence with IDUs or any anecdotal testimony or concern about using injectables with IDUs group?
There hasn't been a protocol that was specific to individuals who are people with injection drug use, or with a history or current substance use. There have been trials that have done that specifically with oral PrEP, but not these long-acting injectables yet. I'd have to go back and look. I think of our friends on the Hank and Legacy team who know this very well. I can't remember if that was a specific exclusion criteria on some of these prevention trials.
Yeah, I'll just say that this is just in general. One of the things that Legacy is focusing on right now is providing guidance around the issue of addictophobia, because oftentimes when you look at a protocol, when it comes to injection drug use or substance use, the principal investigator makes the determination as to whether someone will be an acceptable participant or not. And so, as you might imagine, if there's some bias involved in there, when talk about addictophobia, so that's something we're trying to address, because if there's no real reason to exclude someone from a protocol, we don't want to exclude, a whole community just because of potential bias on the part of one individual. So that's something we're working on. And there are a lot of, really, really amazing people who are working on this issue. So I just wanted to speak to that. And I'm not sure where the question came from, but that is something, as you can imagine, that if people do have issues with folks who use drugs, that those people may automatically be excluded, not because of they may be wonderful candidates, participants, but they're excluded because of someone's, bias. So that I just wanted to just put that out there. Thank you.
I think our friends at NIDA are very interested to advance more research, on long-acting regimens and their use in, populations, of people who are living with injection drug use. So I think there's interested in doing more in that space. I think, you think about kind of like the history of our work in antiretrovirals. There was a time, very early in the oral medications where there was providers who were withholding medicines from people because of their prejudice. That they felt that, because they were an injection drug user, because they had current substance use, they wouldn't be able to handle the adherence to the regimen. And, we've resolutely said that that's not acceptable. And that everyone should have access, and that even people who, are living with a number of challenges can still successfully adhere to and take the therapy. I think that we just have the same kind of interest here, especially because these regimens could conceivably be simplifying for some people. That said, there are people, for whom needles are a difficult reminder, of something that is complicated for them. And so, there is some research to suggest that certain people who have that injection drug use background, they have different feelings about these regimens. So I don't know. So some interesting possibilities there, but also some complexities too.
Okay, next question. Are injectables something that can be injected by a pharmacist, or does it require a visit to the clinic or doctor's office?
I've had this question myself, when I talk to the clinical trialists that we work with, they tell me that they're a little skeptical about the potential for pharmacy delivery of the current regimens. And the reason why is because, so we know, pharmacies there's a lot of amazing things pharmacies can do. And we've certainly seen that, with the COVID vaccines, how they've expanded access to and reach of, access to COVID vaccines. But those are very brief subdermal injections. And what's involved in these long-acting regimens is a very deep intramuscular injection. So the pharmacy providers probably have the expertise to do that, but it is more technically complex. And then in addition to that, it requires, finding a private space, in a pharmacy setting, where people, could, get undressed and receive these injections, in their glutes. And so for, a few of these kind of logistic reasons, people have told me that they're a little skeptical about the potential for pharmacies to deliver these regimens at this time. But they are working on these long-acting regimens, like we were saying, so many different kinds. And one of them is a subdermal injection, which is something that's much, it's very easy to deliver and easier to take. If we can get to that kind of regimen, then that probably is something that could be done in a pharmacy setting, with relative ease. So that would be exciting, because we want to do whatever we can to bring access to these things, into people's communities closer to where they are, if at all possible, out of the clinic and into the community.
Okay, next question. I'm curious how to get the message across between an HIV vaccine and long-acting injectables. Informally, I've heard that people in the community perceive that injectable PrEP is like a vaccine.
I throw that one to Carlos.
Yeah.
I mean, I've dealt with this where we have patients coming in to asking if this is a vaccine. I think I like to ask people, like, where did you get this information? Like, where are you? To make sure that if we can reach out to those folks that are communicating that we can make sure that they're giving out the right message. This just happened to be a friend that read an article and they probably didn't read the whole thing, and so they came into our clinic. I think it's like the education, the way we educate people, the way that we talk about like the process and the follow-up that is needed. We'll tell people that this is not like the vaccine that will, like, you don't have to come back. Like, it's just the way that we present the injectable and the follow-up that comes with it. I think people will get the idea. That's why I'm saying, like, when you give the message, also remember, like, to say, like, prevent HIV, injectable, bi-weekly. That will tell, bi-monthly. That tells people that it's something that they have to take more than just once. Very clear, very to the point. Yeah.
Yeah, and I would also add that currently there is no vaccine to prevent HIV, in addition to everything that Carlos just highlighted.
Yeah, unfortunately, we don't yet have a cure, don't yet have an effective vaccine, but it's like a continuum. So in some of the future long-acting regimens they're working on, they could conceivably be delivered on an annual basis. They're not a vaccine. It continues to be a drug regimen, but that is approaching kind of, you think about like like getting an annual flu shot. That would be really incredible if we were able to get to that level, but we're not there.
Okay, I have a couple more questions. One is about insurance coverage for this. Because my understanding is that public health insurance like Medicare and Medicaid don't cover it, but that private insurance plans or qualified health plans do.
Well, so the financial landscape is one that I don't have the best expertise on. I'll say for myself. I think what I know about it is that it's something that's continuing to evolve, and that decisions are being made in many places where there would be coverage for this. The rationale is that they want to cover these regimens because they think they might be more effective, better, in their outcomes, than an oral regimen. But those choices are still being made by individual plans. Some of the plans, we've seen this in oral PrEP, they still require prior approvals, which can be cumbersome, to deal with. But at the state level, I don't yet know what that picture is, and I apologize for that. This is something that we could look into.
Yeah, Mike, that's my understanding as well. And going back to Carlos, what he pointed out, the issue around cost, and if someone is documented or not, that could be just more barriers, and so it's definitely something that it's problematic currently.
Yeah.
Okay. And just sort of follow up on that, someone is asking, this is not yet available via ADAP, correct?
So, it's ADAP is, those are state level decisions. I think that that's something that's still evolving. So I just, that I'm not certain about it. Sorry for that.
So we are just 1 minute over, and I want to be respectful of everyone's time. Thank you, everyone, for your wisdom, for your time. I do wanted to close on a comment, and I think that as you were talking, I couldn't help but to think about how us, like our organizations, can identify and also form leaders that can actually go to the community and speak in unbiased manner, right? To talk to other peers. I think there's the closeness between peers, between community members, is just something that resonates more. So how can we, not only provide this information, but also develop leadership so that this information is passed along to others, again, unbiased, and so that people can take healthier, informed decisions. And with that, thank you everyone for joining us. Please make sure as you leave the platform to evaluate the webinar. And again, thank you for the panelists.
Thank you all.
See you later.
Thank you, everyone.
Bye-bye.
Well.